For several years, sepsis has been the leading cause of death in Europe, despite the increasing medical focus and the surviving sepsis campaigns. And though biomarkers and clinical scores have been developed to diagnose these incidences early, mortality is still high. Early triage and possibly directing a change of treatment could save lives. suPARnostic is a marker of inflammation, and its use in triage and treatment guidance was discussed together with many other topics during the second International suPAR Symposium in Copenhagen, Denmark during March 2011.
Yeah, well, it's a brand new thing, sort of, with the offering of the prognostic value compared to the diagnostic tools that we already have available, like CRP and BCT, and that's the benefit over the competition.
What we have in our hands is really sort of risk recognition or death signal, overall risk signal, which could really supply us with the signal of this particular patient. Really needs really say strong efforts to find out what actually is wrong.
Well, it seems that it's more stable. We compared it with a CRP, and it seems to be more stable. So it's not like CRP that the values just they are all over the place. They seem to be more stable.
And in Finland, mainly the interest has been so far in the sepsis field and septic conditions and so on, where prognosis is really important, and where no such biomarkers are available at the moment.
When I treat bacteremia patients, I might want to measure suPAR among other inflammatory parameters like leukocytes and CRP, because suPAR might help me to find those patients who need more attention.
I'm trying to find a marker which would tell me ultimately that instead of continuing with the, say, traditional conventional critical care, maybe I could have a marker here for early on recognizing the patients that would need actually some alternative therapy. In case of acute lung injury, that could mean possibly ECMO treatment early on based on this kind of biomarker. I mean, that's the ideal, say, vision that I have for this marker. Highest serum suPAR concentration quartile had 2.5 risk of death related to the critical illness, and this might be sort of, say, access towards clinical intervention, having cut off be it 13 or 14 nanograms per ml, so that these patients might actually benefit from alternative modes of mechanical ventilation.
I can try to give my answer. I think it's very interesting for physicians at triage points. That can be either the ER, like trying to judge how severely ill the patient is. That can be the general practitioner trying to assess, how close of a surveillance does this person need, because he's a smoker, risk of cancer, it's a diabetic, risk of cardiovascular risk. I don't really see that we need to understand everything if we have a clinical relevance, and I think the data become more clear that there is a clinical relevance. But can we predict mortality in these patients, or predict the outcome of these patients? And the answer is very similar to what we saw from Greece, that the patients that will die later during the ICU have much higher levels of suPAR upon admission, and this holds true on day 3 and day 7 as well. But if we plot the Kaplan-Meier curves, we can really see patients that belong to the group of the upper quartile of suPAR levels really differ from the rest with respect to mortality. And this is the ICU mortality, so short-term mortality, if you wish. The same is true if we take the suPAR level on day 3, where it actually splits up even a little bit nicer. If we want to nail it down to a number, to define a threshold, we can say at admission we got the best discrimination between survivors and non-survivors using a cutoff suPAR level of 8. And on day 3 we used a cutoff level of 13, which gave us the best discrimination between both conditions, survivors and non-survivors.
Thinking of the hypothetical case, I would have a suPAR of 12. Who is going to guide me? What am I going to do? Holiday? Stop working?
Certainly, if you were at my outpatient clinic, I would examine you
thoroughly.
Yes, and I would go for blood sample, glucose, cholesterol, and so forth, and I would examine you the same way as I would do with another patient who is in a high risk of having an underlying disease, so like having a fever of unknown reasons and so on. In the medical ward, it's quite different because there are patients who you would like to point out, are they in a special risk if it's not obvious that they are really sick. So I think we could use it at that place.
Conclusion. The dynamical concentration of suPAR, both in patients who survived and died, was different than the other parameters, inflammation parameters. Dynamic of suPAR level is characterized by increased concentration in the event of deterioration and death of the patient and decreased concentrations for effective therapy. That dependency is not visible to other tested parameters. Preliminary results indicate that the evaluation of plasma levels seems to be a useful prognostic parameter of clinical course of disease in a patient treated in intensive care unit.
If we compare suPAR to other biomarkers, we have to say that if we use single biomarkers, the suPAR really seems to do better than, for instance, CRP or procalcitonin, albumin or creatinine, both on the ICU survival as well as overall survival.
So it seems, and we are pretty confident about our results, that suPAR serum levels remain stable within the first 10 days of patients with sepsis. Levels of non-survivors are much higher than survivors. And it seems to be a very good tool for risk assessment. It improves Apache 2 score. It doesn't work alone, but it improves our knowledge. And most important, it's validated in a confirmation cohort from another part of this Europe of more severe patients.
So I guess the way is really to combine suPAR into an integrated model if you really want to predict outcome much better.
And the issue has to do that we miss many of high-risk patients with Apache 2 score. I gave you already an example. And of course, the next question is, what would we do? There are, at least in my country, there are always battles in the emergencies about a patient arriving and whether he should be all of a sudden admitted in the ICU or whether he or she should stay in the general ward. This is one reply. The second reply is that it's obvious that despite Surviving Sepsis campaign and both guidelines published in 2004 and published in 2008, mortality of severe sepsis remains sky high. And this has to do with many ambiguities, many dilemmas we have. We should administer immunomodulation, we should not administer it one way or the other. And I think that scores like that could, let's say, influence in the good way our judgment about how to implement guidelines.
Maybe you should combine it with other markers, biological markers, or the scores we are using nowadays, like the SOFA score or the Apache score, and making a combination of different scores and then use it as a combined marker to make your therapy.
Well, I think later on I'll show some data at the Acute Care medical department or units where I really think that the biomarkers like suPAR and other biomarkers in combination, I think they will help us to trace or to point out the patient who needs more care than others do.
As I told you, ICU mortality is only one part of the coin, and the other is how the patients do on the long run. And also suPAR discriminates quite well between patients that die or stay alive during the long-term follow-up, that the patients with the upper 25% suPAR levels really do very, very poorly on the outcome. And you see here it's, of course, for 2-3 years we have only limited data, so it's not really certain if it really drops here again, but you see that on the long run, high suPAR is really bad.
So suPAR as a test of quality of care.
I agree, there is a lot of young doctors meeting the patients within the first few hours. And my guess is that they could need some help.
Well, it is a young marker, and right now a lot of people are trying it in different fields, and it might be a little bit confusing. But I think at any way it shows that there's one consistent message here, and is the higher the suPAR, the worse the case.
What we find very convincing is that suPAR is a very strong predictor of ICU and of overall mortality in critically ill patients.
Despite the surviving sepsis campaigns, mortality is still high. And as bottlenecks occur in ER and ICU, better tools for triage are needed. Knowledge about prognosis and patient criticality could prevent these bottlenecks. As shown here, suPARnostic has proven to be an important risk assessment tool, as suPAR alone is a better biomarker than other known markers. As suPARnostic has been shown to improve currently used risk scores, the future could hold suPARnostic as a part of an integrated model for better risk assessment and quality of care.